بسم الله الرحمن الرحيم. الأوفاريان lesions كان كذا حد طلب مني الأوفاريان masses. Algorithmic approach to characterization of ovarian masses or adnexal masses accordingly للجايدز classification of the ovarian lesions. What are the ovarian tumors? Ovarian tumors are the leading indication for gynecological surgery. And we said here tumors, but tumors include cystic and solid lesions. So preoperative characterization of complex solid and cystic adnexal masses is crucial for informing the patient about the possible surgical strategies. We have many steps we have to go through. We have step 1 to see if the lesion is ovarian or not. First step, is it ovarian or adnexal non-ovarian lesion? Second step is the ultrasound pattern recognition. Is it simple cyst, hemorrhagic cyst, endometrioma? And when we proceed in the lecture, we will see that hemorrhagic cyst and endometrioma are not an ultrasound diagnosis. If we want to be sure of being hemorrhagic or endometrioma, we must do MRI for characterization. We have also the mature cystic teratoma and the other cysts with different proportions of cystic and solid components. And then step 3 came to see that if it is a low risk lesion and we can follow just, or a high risk lesion which needs further surgical staging. And then we have evaluation with MRI or surgery, and we have follow-up ultrasound to the cases that looks benign and needs only follow-up, and some lesions which are the physiological lesions we can ignore completely. So ovarian cancer is a leading cause of death among women. It is the second most common gynecological cancer after cancer cervix. And it is the 5th common after lung, breast, colorectal, and pancreatic cancer. So we have a high incidence of ovarian cancer also. The problem with ovarian cancer that it is a silent cancer. Sometimes the patient comes with distended abdomen, and she said that the distension may be due to that she's increasing in weight. And unfortunately, when she was first discovered, it's usually there's peritoneal implants and stage 3 and 4 lesions. So regarding the ovarian lesions, here we have clinical examination. In clinical examination, ovarian epithelial cancers, in stage 1A or 1B, survival rate can reach up to 90 to 95%, which usually they are not diagnosed in this stage. Proper management of ovarian cancer depend on the clinical examination. Epithelial, we'll say the classification of ovarian lesions later on, but the most common are the epithelial tumors, and the epithelial tumors are difficult to diagnose in the early stages. Even patients with advanced disease may present with non-specific abdominopelvic symptoms. Laboratory tests like the CA125. CA125 is a useful biomarker. However, elevated CA125 is seen in only 50 to 60% of the mucinous and clear cell variants and in early stage cancer. So it is specific but not so sensitive to the ovarian cancer. And then came the radiological assessment. In ovarian masses, in characterization of ovarian masses, we have a diagnostic challenge. that the ovary is the common site for both benign and malignant neoplastic lesions. In addition, the ovary is a common site of non-neoplastic tumors, including a variety of retention cysts, inflammatory cysts, and endometriotic cysts, which are functional or inflammatory or miscellaneous like the endometriotic cysts. What are the non-neoplastic ovarian lesions? And they are mostly in the form of cystic lesions. Follicular cyst, which is normal follicle that we will take the normal physiological development that occur in the ovary. This is the normal, this diagram shows the normal ovary. The normal ovary show antral follicles. What are the antral follicles? They are small follicles present in the ovarian stroma. And one of these follicles will start to grow in the normal cycle, that is 30 days. It will start to grow in day 8 of the cycle and grow 8 mm per day until it reaches the Graafian follicle size, which reach size of 20 to 25 mm. When it reaches the full size, the follicle starts to ovulate in order to be fertilized inside the fallopian tube. When ovulation occurs, this inflated balloon, as I used to describe, will be shrunken and forming corpus luteum cyst. And then the corpus luteum cyst, if pregnancy occurs, it will be well formed once more and maintain pregnancy until 16 weeks of gestation. If no pregnancy occurs, this corpus luteum will transform into corpus albicans, which is just a scar on the surface of the ovary that may be sometimes calcified, forming calcified corpora albicans on the surface of the ovary. So this is the normal physiology. If this normal physiology does not occur well, we will have these physiological cysts that may occur, that they sometimes, and in most cases, they are transient, only transient cysts. We have the follicular cyst. When this follicle does not emerge, it transformed into cyst, and we say follicular cyst only if the cyst is more than 3 centimeters. Or there may be persistent corpus luteum cyst. Corpus luteum cyst may still be persistent even during pregnancy or without pregnancy. So we say that this is corpus luteum cyst. Cecal lutein cysts occur also when there is increased or hyperstimulation, like in gestational trophoblastic disease, patients taking induction, or with the twin pregnancy, for example. We have also the most common finding of PCO in these days. We have many cases presenting by PCO picture. And usually in the PCO, we say that it is a sonographic picture and must be correlated with the clinical and laboratory findings. Then we have also something related to pregnancy, which is termed pregnancy leutoma, and it is one of the differential diagnoses because it is usually mimicking malignancy. Endometriotic cyst, germinal inclusion cyst, and inflammatory cysts, all these are non-neoplastic ovarian lesions. What is the initial diagnosis or the initial modality of choice? And this is very important, and I will stress on it. Ultrasound, ultrasound, and ultrasound. I usually used to describe that the ultrasound is the stethoscope of the gynecologist. Instead of hearing, he put the probe and we can see what's going inside. So ultrasound is widely available, offers high resolution, there is no ionizing radiation. Significant technological advances have yielded vast improvement in the sonographic depiction of early stage ovarian cancer and in the sonographic discrimination of benign from malignant disease. Then, not only transvaginal ultrasound by itself. Transvaginal ultrasound must be combined all times with color Doppler because it's very important. Because we have something in the ovary here mimicking a solid lesion, however, it's not solid, because there is no vascularity at all inside. So this is not solid lesion. So combining morphological assessment with transvaginal color Doppler features give accurate assessment of the lesion. So instead of saying that this lesion is complex solid and cystic component, no, it is complex cystic with fibrin-like part or clot retraction if it is hemorrhagic cyst, and there is no vascularity at all inside. Any neoplastic lesion, there must be increased vascularity. Here also we have another solid lesion, but it shows increased vascularity inside. It is arising from the surface of the ovary, so this is a surface epithelial neoplastic lesion. There is associated ascites, so this is with malignancy. Then we came to the classifications known as the Guyrat's classification and now the Oral's classification. What is this classification? It is just like pyrades of the breast. We have to mark the lesion 1, 2, 3, 4, 5 according to the proportion or the suspicion of malignancy and benignity. So we have the Guyrat's lesion. This is assessment of adnexal masses, not only ovarian. So other differential diagnoses of adnexal masses are included in this category. The Guyrat's category, Guyrat's 1, means normal ovaries, no adnexal masses seen. This is a normal ovary, this uterus, a normal ovary, and there is no adnexal masses seen. Guyrat's 2 are functional origin cysts, like a follicular cyst or follicle, like a corpus luteum, and usually the corpus luteum may have different appearance. It may appear as mimicking completely solid lesion. It may be corrugated outline, so it has different appearance, we will see later. And hemorrhagic cyst like that, and usually hemorrhagic cyst usually disappears after 1 or 2 cycles, so give it time. So this is the adnexal lesions of functional origin. Then came the neoplastic lesions that are thought to be benign, like the endometrioma, which has a typical appearance of low-level internal echoes within, typical appearance of teratoma with dot-dash appearance and tip of iceberg sign, hydrosalpinx, tubular structure like that, oblong tubular structure in the adnexal region, para-ovarian cyst, the presence of a cyst beside a normal ovary, and pedunculated leiomyoma or pedunculated fibroid. All these are benign entities, but sometimes we need MRI for characterization. Then came adnexal lesion, Guyrat's 4, adnexal lesion with 1 or 2 findings suggestive of malignancy, like it appears cystic, but it has a small solid component or thick septa within, so this is a sign of malignancy. Or adnexal mass with 3 or more findings suggestive of malignancy, so this is more towards malignancy, so it is Guyrat's 5. All these are findings related to the primary tumor present, and sometimes we have secondary signs which ensure that it is a malignant lesion, like the presence of ascites or implants present. So this is the Guyrat's category of ovarian lesions. Ultrasound features used in the International Ovarian Tumor Analysis, IOTA classification. The simple rules of IOTA classification, just very simply, those on the left side, they are benign, and those on the right side, they are malignant. Those on the right side, simple cyst with thin wall, simple cyst with a small papillae less than 7 millimeter. Acoustic shadowing, the hyperechoic lesion is usually with fat, so the presence of fat in a lesion is sign of benignity. Smooth multilocular tumor with diameter less than 10 centimeter. No blood vessels at all inside, this is with benignity, like the previous slide, where we see that there is echogenic structure inside, but it has no blood vessels at all inside. On the counterpart, the malignant lesion have a regular solid component, presence of ascites, presence of peritoneal implants, presence of papillary projections within the cyst more than 7 millimeter, a regular multilocular solid component, the size more than 10 centimeter, but however the size is not so specific because sometimes we found benign lesions with a very huge large size like the serous cyst adenoma. It may reach a very large size. Then came the Doppler. This is the typical malignant circulation where we have high vascularity, lack of arborization, large central vessels with arteriovenous shunting. All this we give it color score 4. This is a malignant circulation. And this is color score 1, where there is no vascularity inside at all. This is the ORAD's lexicon. ORAD's related to the ovarian. Here in the gyrads, it is ovarian and adnexal, like in the ORAD's, it is only ovarian. And here we have ORAD's 0. There is incomplete evaluation and needs alternate study or repeated study. Sometimes we could not by ultrasound identify the abnormality and we need further assessment by other modality. ORAD's 1, it is almost certainly benign with malignancy less than 1%, like the simple cyst, the classic benign lesions like endometriomas, classically benign lesions with normal with ultrasound related to benignity. Non-simple unilocular cyst with a smooth inner margin. This is also in the ORAD's 1. We have also the ORAD's 2, 3, 4, and 5. 3 with low risk of malignancy, nearly similar to the PIRADS classification of the breast, nearly similar to them. But here we have certain features and certain specifications that make us, we put ORAD 1 or ORAD 2 according to the lesion. And here also in this table we can see the management. What is the management then we can do? Do we know we need ultrasound, MRI, or do we need to manage because it is towards malignancy, so we have to visit a gynecologist or oncologist. So this is the management of these ovarian lesions. And here also we have these figures beautifully showing the normal, this is the ORAD's 1. ORAD's 1 means normal ovary, so we have the likelihood of malignancy 0. We have here a follicle, less than or equals 3 centimeter, it is just a follicle. It's not even a follicular cyst. So this is a follicle, and this is the normal appearance on ultrasound, and here this is the normal ovary. So this is normal follicle, normal ovary with a normal dominant follicle. Usually the dominant follicle is smooth in outline, anechoic, and not irregular in appearance. Then we have the corpus luteum cyst. The corpus luteum cyst is a thick-walled cyst, less than or equals 3 centimeter, with crenulated inner margin. And this is what I described before, that it may look like a balloon, and this balloon starts to deflate, so it gives this appearance. And we have a peripheral ring of fire appearance, and this is very important because the ovary at that stage is preparing itself that pregnancy may occur, and this corpus luteum will maintain pregnancy later on. Or it may show this appearance: hypoechoic region with peripheral flow without characteristic cystic component. It appears as if it looks like solid, but again, there is no blood vessels inside. And the patient is in the second half of the cycle, so this is with corpus luteum cyst. ORAD's 2 lesion, and this is the normal appearance of ORAD's 2 classic benign lesions. Typical hemorrhagic appearance, but still, I told you that even with the appearance of this typical hemorrhagic appearance, we don't in ultrasound write directly it is a hemorrhagic lesion, because the only that can identify the blood is the MRI. So here we have different appearance of the hemorrhagic system. This is the clot retraction, I say to you. This is the clot retraction, and here the fine low level internal echoes within. So that the typical hemorrhagic appearance. This is the typical dermoid-like dermoid. This is the typical mature cystic teratoma, where we found here the tip of iceberg sign, or the floating fat balls, or the dot dash appearance like the hair of the fetus. So this is the typical dermoid appearance. Typical endometrioma showing the low level internal echoes within. That sometimes it appears as if it is solid. And sometimes we have to characterizing that it is ovarian, because there is ovarian peaking around the lesion. This is the simple para-ovarian cyst.